I'll tell you, I'm not very comfortable speaking behind a podium, so if I start wandering back and forth, it's not you, it's me. So thank you for letting me come. Honestly, we've been doing these conversations now throughout the community, and we've been doing them in different churches, and we've been doing them through the hospital. And basically what we're trying to do is start the conversation. Just get the word out there that this is important, and this is something that we want you to take away and say, this is something I should think about for myself. So if I generate more questions today than I answer, I've done my job. I really want you guys to kind of think about how this works for you and what this means for you and your family. So I'm not here to give you all the answers. There are no all the answers. This is an individual thing that you have to do on your own. I would really love this to be a dialogue. I've got a whole bunch of slides. We don't have to make it through them, believe me. They told me I have 3 hours, so if it doesn't, I'm sorry, was that 4? I'm sorry. If we don't make it through the slides, we don't make it through the slides. I really want you guys to walk out of here feeling like you got what you needed, okay? Let you know a little something about myself. I'm a family physician. I did my training at the University of Iowa and then did my residency program here in town. So Becky and I have known each other for a very long time. I had my own practice here in town for quite a while, and then was fortunate about 10 years ago, they asked me if I would be a teacher over at the residency program. And I thought they would figure out in about 6 months that I didn't know anything, and that was 11 years ago. So they haven't figured it out yet. And just recently, they made me the program director. So it's a place that I very much love. If you have any questions about family medicine residency programs, let me know. A little more important than that, though, I have a passion, and that is a very big part of what we do in medicine is take care of people at the very end. And I don't want to burst anyone's bubble, but the mortality rate for human beings in the United States is still 100%. You will all die. I will die. And in fact, one of the first things they taught us in medical school was everyone dies. Our goal is not to try to keep anybody alive forever, right? It doesn't happen. It won't happen. It's how we take care of each other and how we take care of ourselves up until the point that we die, and what kind of quality and what kind of control and what kind of dignity can we give to a patient for that entire time. Whether we live to be 40 or 80 or 140, it doesn't matter to us as long as there's quality involved with that. So we look at things a little bit differently sometimes when we sit there and say, there is no such thing in medicine as a pill that will keep you alive forever. And people come in asking for that pill, and people want that pill. It doesn't exist. So taking care of patients at the end of life is something that I think is very important. I had the privilege of being the medical director for the Genesis Hospice program from about 2005 until about 2011. During that period of time, the hospice house opened up. So I had all kinds of very amazing experiences with hospice and the hospice house. But one of the things that I really wanted to do was go into palliative care, because I think as important as hospice is, I think palliative care also offers amazing abilities to have those conversations with patients. And we'll talk a little bit more about what palliative care is. Just out of curiosity, how many of you have had any experience with palliative care? A smattering. Okay. There'll be a lot to learn. Okay. I want to start off with a patient. Mrs. Jones. She's 82 years old. Her husband died a few years back. She lives alone now. She's still in her own home. She's able to do most everything for herself. She has 2 daughters that live in the community, and they do come and they visit her on a regular basis. And they help her with trips to the store and errands and other things that she needs. She has a very strong church family as well. She's had kind of the usual things we might think about for an individual who's 82. She's had some problems with her blood sugars. She's had a little bit of elevated blood pressure that she takes medicine for. She's had a little bit of cholesterol problems. She's got a little touch of congestive heart failure. She had a stent placed in her heart a couple of years ago and has done very, very well since then. So the question that I would ask you is there anything unusual about Mrs. Jones? Anything that pop out at you? Pardon me? She's living at home. You know, the thing that pops out to me is just how utterly normal she is. She's 82. She's still in her own home. She has some health conditions, but she's doing well. 25 years ago, when I went to medical school, we didn't expect men to live much longer than 72. That was kind of as long as we thought most men would live, which, you think about retirement at 65. If you had 5, 6 good years thereafter, you're doing pretty good. Females a little better than that, but you know what? It just gets longer and longer and longer. And people are doing better, and people are living longer, and they're doing well and doing it in their own homes and staying in their own homes. And we're doing a better job of taking care of people. But part of that is what goes along with that. Almost all of them have some kind of health condition that they're living with, right? Chronic health conditions are becoming a very real part of what we do now in medicine. So we talk about the fact that about 50% of all adults have at least one chronic condition that they're dealing with, whether that be high blood pressure or cholesterol or their sugars, the heart condition, a lung condition, something that they're dealing with. And about 25% of adults have at least two or more. This is just something that's now a part of our society. I love history. If you think back to the 1950s and medicine in the 50s, what was medicine like? One, the doctor came to your house. You didn't go to the doctor. And two, you didn't go for chronic health problems. You went to see the doctor when you were sick. You didn't go there for preventive health. You didn't go there to make sure your sugars were under control or your cholesterol was under control. You went when you were sick. What a different world we live in. Medicine has changed so much that now medicine is, you still go to the doctor when you feel sick, but the vast majority of my day is no longer taking care of people who feel ill. The vast majority of my day is taking care of those people who are still healthy in an attempt to keep them healthy. And that's what we do in medicine now. That's pretty much my day. I spend the vast majority of my day taking care of people with diabetes or hypertension or hyperlipidemia. That's what family medicine is. That's when you go see your primary care doctor. 7 of the top 10 causes of death are from chronic diseases. Not a surprise, right? Heart disease, lung disease, cancers, renal disease. This is what we take care of. This is what people end up eventually dying from. 2 chronic diseases account for almost half of all the deaths in the United States, if you just add heart disease and cancer together. This is what medicine is like. Yes, we're doing a better job of keeping people in their homes, and we're doing a better job of keeping people healthy for a much longer period of time. But chronic diseases is definitely a part of what we do now. Surprising to anyone? That's just the world we live in now. So how does this affect society? One of the things that's very much a part of this is there's a cost to this. We spend more money in the United States on healthcare than any country in the world. We're almost up to measuring healthcare dollars in the trillions. We have 3 buckets of cash in the United States. One is what we spend on defense. One is what we spend on health, and then the bucket for everything else. Literally a third of everything we spend in the United States is on health. And that's just some numbers there. Just, $315 billion a year is spent on heart disease and stroke. $157 billion on cancer, $245 billion on diabetes. Down at the bottom there, some of the things we do to ourselves, tobacco use and alcohol use. You add that up, that's over $500,000, $500 billion that we spend just on those 2 diseases alone. You start adding $1 billion here and $1 billion here, it starts to add up, right? This is some real cash that we spend on healthcare. In 2030, about 1 in 5 people in the United States will be over the age of 65. We have an aging society. Healthcare dollars will certainly not go down. We're going to spend more on healthcare, especially as people get older and they have more chronic health conditions. It just goes hand in hand. The interesting thing is, if you look at where do we spend the vast majority of that money, we spend the vast majority of that money in the last 6 months of life. Almost 50% of all Medicare dollars is spent in the last 6 months of life. This is something that we have to look at and say, how do we deal with this? How do we best take care of people at the end of life? Because this is a big deal. Look at the numbers. I apologize, it's a little old. This is 2009 from the New York Times. But if you looked at New York University, in the last 2 years of a patient's life, they spent about $105,000 per patient. 31 days in the hospital, 77 doctor visits just in the last 6 months alone. Now, how do you compare that to the Midwest? Obviously we do a lot of things better here in the Midwest, but Genesis was actually one of the most aggressive hospitals in the state. I mean, we have this amazing cardiology building over here. That means they got to pay for that amazing cardiology building. We do a lot of procedures in this town. There's a lot of stents walking around in this community, and that's not necessarily a bad thing, but we are considered to be one of the most aggressive hospitals in the state. We're at $40,000 per patient in the last 2 years of life, with 14 hospital days and 29 hospital doctor visits. There's a lot of health care that goes on in the last 6 months. So how do we best take care of patients? It goes a lot beyond just dollars though, right? When somebody is sick, when somebody has a significant chronic illness, there's all kinds of loss. There's loss of productivity, there's loss of income, there's loss of independence, there's loss of some of that ability to make decisions for yourself. And all of that takes a toll. I'm sure all of you have seen spouses that have cared for a spouse that's been sick, and they don't get the chance at the end of life to be a spouse. They're a care provider. And that takes a huge toll on family. There's children that end up being care providers for their parents. Obviously, that takes a toll on families as well. There's all kinds of non-monetary things that happen at the end of life. So a significant cost to society for all of the things that we were able to do in medicine to help people to have better quality for a longer period of time. Just an interesting thing to think about a little bit. But I want to get back to our case. All right, so Mrs. Jones, she's doing well up until she starts having some problems with some shortness of breath. She starts having more difficulty at night, can't breathe very well, starts using a couple of pillows to prop herself up because she can breathe a little better that way. She starts putting some fluid in her ankles. She gains a few pounds. She goes to see her doctor and they say, you know what, I think you might have a problem with your heart. I think you got some extra fluid building up. I think we better put you in the hospital. So Mrs. Jones goes into the hospital. As they are admitting her to the hospital, what question are they required to ask? Do you have a living will? Or do you want information about advance directives? Does anybody know why they asked that question? It's a federal law. Did anybody know that? I think they are required to ask, do you have an advance directive? And we're going to be talking a little bit about what advance directives are. But I think it's kind of fun sometimes to go back in history and find out why is it a federal law that you have to ask that? And the reason is Nancy Cruzan. Anybody remember her? Nancy Cruzan, 1983. She was 26 years old. She was in a motor vehicle accident. She was in a persistent vegetative state. Now, what does that mean? A persistent vegetative state means that the front part of her brain, the part that allows you to think and reason and have a personality and communicate and be able to be a person, was destroyed in the car accident. The back part of her brain that made the heart beat and the lungs breathe was still alive. So she was still alive, but she couldn't be a human being. She couldn't talk. She couldn't communicate. She couldn't think. She couldn't hear. She couldn't listen. She couldn't feel. She couldn't, all of the things that make us human beings. She was basically just kept alive. And she couldn't swallow, so they had a feeding tube in, and she was being kept alive on a feeding tube. And in 1986, so 3 years later, the parents had waited 3 years and she wasn't waking up and there was no improvement, and they went to the hospital and they said, I would like to have this feeding tube removed. I think all we're doing is keeping her alive. We're not really giving her any life. The hospital said, no. Removing that feeding tube would literally be killing your daughter. We will not do that. We refuse to remove the feeding tube. So they went to court, and the court agreed with the parents and said, yeah, if this is in keeping with what the patient would want, you can remove the feeding tube. That's okay. So the hospital took it up to the Missouri Supreme Court. And the Missouri Supreme Court said, no, you can't remove that feeding tube. That would be killing the patient. So the case went all the way up to the Supreme Court in 1990. So remember, she had her accident in 83. 7 years later, this poor young lady is still being kept alive with a feeding tube. The Supreme Court made a decision, and this is a an amazing decision. And this is only 1990. What? So this is 26 years ago? This is pretty new. 26 years ago, the Supreme Court said that if it's in best interest of the patient and is what the patient would want, it's okay. So it's okay to take a person off a ventilator if that's what the patient would want. It's okay to remove a feeding tube if that's what the patient would want. It's okay to stop dialysis if that's what the patient would want. It's okay to, all of the things that we can do to keep a person alive for a long period of time. It's okay as long as that's what the patient wants. And so they kind of set this up that patients have the right to refuse medical care if that's not what they want. Doesn't that sound crazy? I mean, before that, the patient didn't have a choice? If you were a candidate for dialysis, you got dialysis. That's just the way it went. If you were a candidate for a feeding tube, you got a feed. They finally said that now the patient gets to decide for themselves. 26 years ago. I mean, that's just crazy. So Senator Danforth, who was from Missouri, remember that's where Nancy Cruzan was from Missouri. Senator Danforth put together the PSDA bill, which basically says that anytime anybody is admitted to a hospital or a nursing home or other care facility, they have to be asked the question, do you have advanced directives? And if not, would you like information on advanced directives? This became a federal law, and that is why Genesis, every time you admit somebody to Genesis or Trinity or Unity Point or any place, anywhere in the country, you will be asked, do you have advanced directives? And if not, would you like information on it? If we have been asking this question for 26 years, why is it that so few people have advanced directives? That's amazing to me. That's absolutely amazing to me. The federal government put it in our hands, the people's hands, that we can make these decisions for ourselves, and we can decide what's important to us, and we can decide what we want in the end of life. And yet, so few people have gone that next step to say, this is what I think is important. This is what I think I would want for myself. So why do we go around to the different churches, and why do we go around the community, and why do we hold these meetings at hospitals and what have you? We're trying to catch up. We're trying to catch up 26 years later and let you guys know you have that right. It's your decision. It's not the physicians who are caring for you. It's not the nurses who are caring for you. It's not even your family's decision. It's yours. You have that right. Thank you, Nancy Cruzan. But that was a long time in coming. So basically the idea was we're going to protect patients. We're going to facilitate the communication between patients and their physicians, and in so doing, we may prevent unwanted treatment. Down road, we may save some money, but that's not the reason for doing this. The reason for doing this is to do what's right. So you don't keep a young lady on a feeding tube for 7 years long after she and her family would not want that. What kind of advanced directives exist? There's all kinds out there, and we're going to kind of go over these different kinds. Which one of these is best? No such thing. I'm going to give you my opinions, but it's an opinion, right? But some of these are some different things. So living will, durable power of attorney, DNR orders, medical directives, values, history. I'm going to go each one of these individually. So a living will. A living will is basically just a document that says, this is what I would want should I not be able to make this decision for myself any longer. I have seen thousands of living wills, and I don't think they're that helpful. Most of the time, it's a one-sentence statement signed by the patient. And the sentence basically reads something like, and it can change, but it says something like, in the event that I have a catastrophic injury, I would not want any aggressive cares. And the patient signs it. What is an aggressive care? That's really gray, right? So is aggressive care, you wouldn't want a feeding tube, but you would want everything else? Or is aggressive care, you'd be okay with a feeding tube, but I certainly wouldn't want dialysis? Or I'd be okay with a feeding tube and dialysis, but don't ever put me on a ventilator? Or I would be okay with a ventilator, but I don't know. That sentence means very little to me. I don't know how to interpret that sentence. And we have a lot of people that come in and say, I have a living will, I'm covered. I don't know that that covers it. I'm not a huge fan of living wills. Maybe you picked up on that, I don't know. Not sure that's what you think I'm not sure it does what you think it does. A single sentence that says, I would not want aggressive cares. There is no book out there that says, these 12 things are aggressive cares, these 12 things are not aggressive cares. That book doesn't exist, so don't be going in there saying, well, they obviously know what's aggressive care. We don't know how you are going to present. Not a huge fan of that sentence. We're going to go a little further than that. The durable power of attorney for health care. Huge believer in this one. I love this one. This one is fantastic. What does that mean? That means if you are in the hospital and you've had something terrible happen and you can't talk to us or speak to us or reason enough that you can answer our question, what would you like us to do? You have put on paper, who do you think is best going to decide what you would want? Sometimes that might be a spouse. Sometimes it might be a child, a daughter, a son. Sometimes it might be your neighbor. Sometimes it might be the postman if he's the one that best knows what you would want. The important thing is, choose somebody who agrees with you, right? If you are of the opinion that I would want a feeding tube, and I would want a ventilator, and I would want dialysis, and I want all those things, and your spouse says, oh, kill the bum. Don't choose that person. That's the wrong person. Choose the person who's going to agree with what you want, right? So you have to choose a little carefully, and sometimes that takes a conversation. You may have several kids, and 3 of them don't agree with what you would want, and 1 does. Which one are you going to choose? The one, right? But you got to have that conversation because you got to know. The other thing is, whoever you choose to be your durable power of attorney, you have to sit down and have a conversation with them. You have to sit down and say, this is what I would want in certain situations. Now, you can't go over every situation, right? If I'm in a car accident and my right arm is injured but not my left, I want this. Or if I'm in a car accident and I have this leg but not that. You can't go over every situation, but you can go over saying, you know what, if I'm in a situation where it doesn't look like I'm going to be able to have this quality of life, this is what I would want you to do. Let them know so that they can help us make those decisions. And then get that in writing, because that's really helpful to us. Because if we don't have it in writing, we do have a formula that we go by. We go to the spouse first, and then the eldest children, and then the parents, and then the brothers and sisters, and we work our way down the algorithm. But we'd much rather have a piece of paper saying, who do you want us to turn to? And please choose one person. We have so many times when people say, I have 4 kids, I want them all to decide. When was the last time your 4 kids ever agreed on anything? One person would be really, really helpful. So I'm a big fan. Durable power of attorneys. Do it. Absolutely do it. You'll never go wrong. If you're able to make decisions for yourself right up until the day you die, who makes the decisions? You do. If you're not able to, it's nice to know who you want us to trust. That makes a big difference. DNR orders. DNR orders tell us whether or not you want us to restart your heart after your heart stops. That's it. After you die, do you want us to try to bring you back? That's it. That's all a DNR order is. And a lot of people get confused because they think DNR means more than that. It doesn't. That's it. That's all it does. After you die, do you want us to try to bring your heart back? Because how long do people live without a heart? That's it, right? That's the end. So if your heart stops, do you want us to bring it back? Now, people think that means I don't want medicines, or I don't want to be in the hospital, or I don't know what other people think it means. It doesn't mean that. It just means only if my heart stops, do you want me to bring you back? All right? That's what that is. So basically, do you want us to do chest compressions and give you electricity to try to get your heart started again? So that's what that CPR is. And honestly, that's all that means. I think DNR will not exist in about 5 years. In this country, we're really moving away from do not resuscitate to allow natural death, an AND instead of a DNR. DNR, we can talk about that. I wasn't going to go into this, but we'll talk about it a little bit. DNR basically sounds like you have two choices, right? We're either going to restart your heart or we're not going to try. The truth of the matter is, if your heart stops, in the best of circumstances, what are the odds that we will successfully restart your heart? If you look at television and all of the evidence-based shows we have, like Grey's Anatomy and House and all of those kind of things, what percentage of the time are they successful on House? Roughly 100.3%, right. I haven't done the actual math. In real life, if you look at the studies, in real life, what percentage of the time are we able to restart a heart that has stopped? It's roughly 1 in 10. It's about 12%, about 1 in 10. That means about 90% of the time, as hard as we try, as with all the best technology that we have, once a heart stops, it's not real good odds it's going to start again. Do not resuscitate kind of makes it sound like, well, if we just had tried, we would have succeeded. It's not quite that simple. So I think we're going to get away from that terminology. I hope we get away from that terminology. I think the terminology is bad. I think it just, if I just let the doctors try, I would have had 27 years more of healthy life. You know, it's not that simple. Once your heart stops, that's usually a pretty bad sign. So I think that's going to go away, and I think we're going to go to allow natural death, which basically means we understand that when your heart stops, that's usually the end, and we're going to allow that to happen. So I think that's where we're heading. Okay, medical directive, another one that I'm not hugely keen on, because this is basically you saying, in this situation, this is what I would want. If I were to have a massive stroke, I would want this, this, or this. If I were to have a massive heart attack, I would want this, this, or this. If I were to have a terrible diving accident in Acapulco, I would want this, this, or this, right? How can you cover all the odds? You just can't. And so medical directives are basically you saying, what would I want in different situations? And it's just almost impossible to cover the odds. You can put some generalities. If I were to be in a situation where I had no good brain function, I wasn't going to be able to wake up, I wasn't going to be able to answer questions, what have you, I would want this or this. I think those are okay. But it's really hard to come up with everything that could possibly happen. Not a huge fan. I would much rather, if I had the choice, I would much rather you do this. This is something called a values history. Even if you did nothing else, if you sat down with your loved ones and went through a values history with your loved ones, I would say, well done. Because basically what a values history is, it asks you very, very, very broad questions, such as, what does it take for you to say you have good quality of life? That's as broad as it gets, right? What would it take for me to say I have good quality of life? Would I have to be able to communicate with my family? Would I have to be able to walk and take care of myself? Would I have to be able to enjoy music? Would I have to be able to, what would it take for you to have quality in your life? No one's going to hold you to any of these. But it is a great place to start conversations. And there's a great place called 5 Wishes. And if you go to agingwithdignity.com, there's a place there where you can download these questions. I don't think it costs anything. I think it's free. I would say if you did nothing else, if you went through and looked at those questions, and don't do them alone, do them with the people you really care about, so that they know what's important to you as well. And recognize this as well, please. Whatever you say is most important to you today may not be the most important things to you 6 months from now, or a year from now, or 2 years from now. Recognize that these change as your family changes, as you change, as your health changes, as your quality of life changes. Your values change as well. Have those conversations. If you do nothing else, if you take nothing else from today, this is a great place to start. And think about what's important to you in your life and what gives you value. There are two forms I'm just going to talk about real briefly. One for Iowa, one for Illinois. One is called the I-Post form, which is the Iowa Physicians' Orders for Sustained Therapy, and the POST form, which is Physicians' Orders for Life-Sustained Therapy. Anywhere you go in the United States now, basically these forms are coming into vogue. Iowa made it a state law about 2 years ago that the I-Post is the official advanced directives form for the state of Iowa. And the I-Post is only for individuals who have a significant chronic illness that may or may not end their life. So it's really not designed to be filled out by 25-year-old young people who, they've got nothing going on. But basically, the I-Post and the POST are almost identical forms, and it's the same as I think there's a form called the MOLST, M-O-L-S-T, which is the Missouri form, and there's almost every state has one now. But basically, it asks 3 questions. The first question is, what would you want us to do if your heart stops? And you have 2 options. I would want you to do CPR and use electricity and try to get my heart started again, or just make me comfortable. So what happens if my heart stops? The second question is, what if you stop breathing? You have 3 options here. I would want you to put me on a ventilator and do everything you need to keep me breathing. Or let's not use a ventilator, but you can use a mask or whatever other instrument that's non-invasive to help me breathe. Or 3, just keep me comfortable. And then the last question is, what if you needed a feeding tube? And they give you 3 options here too. 1, I would want a feeding tube for as long as I needed it. 2, I would want a feeding tube for a short period of time to see how I tolerated it. Or 3, just keep me comfortable. To be legal, the I-Post is supposed to be on salmon-colored paper. Why salmon? That's what they chose. And POST form is on this bright pink paper, which is just, you cannot miss it, right? So the idea being that if you were in your home and you had this, on the refrigerator and the paramedics came in, they would recognize it immediately. They'd see this salmon-colored paper or this bright pink paper if you lived in Illinois, and they'd be able to grab it and take it to the hospital, and they would know what you wanted. But you can download this. It's online. You can get it anywhere at the hospital. You should be able to get it from your doctor's office. I know several lawyers have them in their office as well. And again, even if it does nothing else but make you start having the conversation and you talk with your family and you talk with your loved ones about, this is what I would want, it doesn't matter what you choose, right? It doesn't matter if you choose the most aggressive. It doesn't matter if you choose the least aggressive. It doesn't if you choose the middle. It doesn't matter what you choose. What's important is you talk to your family about what you wanted. So if it does nothing more than encourage you to have the conversation, it's done its job. And no matter what you put in this form, if you come to the hospital and you request something else, what takes precedence? What you say, right? So, people are always afraid to put down in writing, I do want this or don't want this or what have you, because they say, well, what if I go to the hospital and I say I want to be intubated, and they say, oh, we can't hear. It says, you said you didn't want that, so can't do that. No, what you say goes, right? So whatever you want, whatever's best for you at that moment is what we should be doing for you, right? And even if you have in writing, we always use the example, somebody comes in and they have a pneumonia, and we have every expectation that 2 days from now you're going to be up doing fine, but we might need to support your breathing for 2 days. Would we would we intubate somebody? Yes. If that's what it would take to give you quality of life and it's the right thing to do. It's not like you have this on a piece of paper and all of a sudden, everybody walks in the room and go, oh, they got that piece of paper, walk out. That's not how it works. It really is what's best for you in that situation. But it does give us an idea. So I wouldn't recommend putting down things you don't particularly want just so that you know that somebody can overdo it. Again, use this as a deciding thing to say, this is what I think I would want for myself. And there are some people who say, yeah, I want everything aggressive. And there are some people who say, I want nothing aggressive. Okay, true story, this really happens. You're in the emergency room, and Dad is in the room, and we need to make a decision quick about whether we want to intubate Dad, right? And there are 5 family members there in the room. This person says, oh my gosh, we got to intubate Dad, this is ridiculous. This person says, Dad would never want to be intubated. This person says, I don't know. I'm not really sure what we should do. You go around and nobody has an idea. You change the question. And instead of asking, what do you think we should do for Dad? You say, what does your father want? You go around the room and the first person says, oh man, Dad said, whatever you do, don't ever put me on a ventilator. Second person says, oh yeah, Dad said if we ever put him on a ventilator, he's going to come back and haunt us. And the third person says, whatever, don't put Dad on a ventilator. And you go around the room and all of a sudden everybody's on the same page, right? Because Dad had the conversation. And I think most important thing, I don't care what you put on paper. I know that sounds bad, but I really don't care. As long as you have the conversation. Talk to your family. Because it makes all the difference in the world at that point if everybody's speaking the same language and everybody in that room is saying, yep, that's what Dad always said. Then we know what to do, right? We know what's right for Dad because he's had the conversation. It becomes a lot harder when you walk into that room and you got 5 family members and you say, did your dad ever talk about what he would want? And they go, oh, Dad didn't ever want to talk about that. And that happens too. Again, these are questions I'd much rather you ask, talk about these things before your heart ever stops. What it really comes down to is that's not a decision that your doctor wants to make for you. It's not a decision that we want to make, in a split-second decision in the emergency room. We really want it to be a decision that you've made long in advance, preferably when you were healthy, rather than trying to make that decision when you've got, literally, I got less than 5 minutes to make this decision. I can't do that, right? I can't make that decision and call up the family, try to get a hold of everybody, try to make the right decision. We're just going to do what we always do. We just do everything, right? In lieu of having any information, we do everything. The idea being you have that right to make that decision long before you have that 5 minutes to make the decision. So our goal here is to encourage you to have that talk long before we get to the point where you've got 5 minutes to make a decision. That's why I talk about the conversation being so important. It's all very rare that we don't have somebody there. Having had that conversation is probably more important than any paperwork that you have. Second thing is if you have that conversation with your doctor as well, and the doctor has that paperwork, I can pull that up as long as it's a doctor that has the same computer system, which in this town is almost everybody. I can pull that up pretty quick. But I'd much rather you talk to your family. All right, we talked about most of this. Who should have advance directives? The crazy thing is that those individuals who are not able to make decisions for themselves, rarely do they have advance directives. Rarely have they gone through this. About 20% of the time. That means that 4 times out of 5 we're sitting down with family and saying, what would your father want? What would your mother want? What would your loved person, what would they want? And they say, I don't know, we never had this conversation. That's what these conversations are about. Let's encourage people to have these conversations so that we know. And when should that conversation take place? Long before you're in the emergency room. That's a bad time to say, well, I'll talk about it when I'm dying. Don't do that. Have that conversation long before. Just an interesting statistic. This is a little old. It's 2009. But these were patients who were on a ventilator. They'd already been on a ventilator long enough to have the tube put in their throat. So they were now breathing through their throat. These are patients who had already been in the intensive care unit for probably weeks. Of those, only 21%, about 1 in 5, had said, this is who I want to help me make decisions for myself. The other 4 and 5 just expected that, we were going to guess? About 16% had actually filled out an advance directive. And only 35% of them were DNR. So in other words, I guess we just do everything. We don't know. We don't know who to talk to. Those numbers are appalling to me because I don't want to make that decision for you. I don't want it to be my decision what we do. I want it to be your decision. That study's a little old, but I don't think those numbers are that far off. That's about what we see walk into the hospital every day. About 1 in 5. All right, how often should we have these conversations? Remember I said things change? Your health changes, you get younger, or you get older, either one. You have grandchildren, or you have other things in your life that make a difference to what's important to you, and your decisions change. So you know what? About every year is a good time to do that. And you should probably have this conversation about once a year with your doctor. That's our recommendation. Because After about a year, things change, right? Your life changes, your health changes, your what's important to you changes. So about every year. So do they work? If you have them, it's great. But again, this is a little old, but this is the best study we've ever done looking at advanced directives. And remember, this is 5 years after it became a federal law that you had to ask about advanced directives. So 5 years later, only about 20% of people had them. 12% had actually talked to their doctor about it. 5% had actually get anything in there that said, this is what I actually want. And only about half of the time did the doctors actually follow that. The numbers are appalling. 50% of all DNR orders were written 2 days before the patient died. That means they were waiting to the very last moment to think about what was important to them, right? These should not be decisions when you're literally dying. This would be great to have these decisions made when you're actually well, when things are going well. I hate those last two numbers. 38% of deaths occurred after you've been in the ICU for 10 days. That means we were being horribly, horribly aggressive. You remember talk about 48% of all costs of healthcare are in the last 6 months of life. There you go. There's the last 10 days of life. I don't know if you guys have ever looked at the cost of 1 day in the ICU. It's not pretty. And about 50% of conscious patients were in moderate to severe pain at least half the time. That means we're just not doing it right. We're doing this wrong. People change their minds. Different cultures have different ways of thinking about things, and that's okay. The most important thing is have the conversation. So we need to have these conversations with the physicians. We need to document them, have them in writing somewhere, have them in writing at your doctor's office, have that be available as an option, but continue the conversation. Have it more than one time. Talk about this more than once, because this is important stuff. Let's get back to Mrs. Jones. She was released from the hospital after a few days, but you know what? She just has some problems being able to get back to her previous level of functioning. If she was functioning up here, she has this hospital stay. You know what? Now she's functioning about here. Is that unusual? It's exactly the way it happens. And then they have another hospital stay, and now they're down here. And then another hospital stay. And it's very difficult to get back to that level of functioning. So she's more dependent on her kids. She has to go back to the hospital a few more times. She's getting very frustrated. She isn't able to do what she was able to do just a few months ago. Unusual? Or have we seen this over and over and over? Over and over and over. This is exactly what happens. Is there anyone at the hospital that can help her? I want to talk to you guys about what palliative care is. So palliative care is a fairly new branch of medicine. It is a specialty in and of itself. And the idea behind palliative care is that we deal with quality of life. And we don't try to fix diseases. So we're not lung doctors, we're not heart doctors, we're not kidney doctors. We are doctors and nurses and social workers and chaplains who deal with quality. What can we do to give you improved quality of life? And we still have them see their heart doctor, and they still see their lung doctor, and they still see their kidney doctor, but the palliative doctors are talking to the lung doctors, and they're talking to the heart doctors, and they're talking to the kidney doctors, and trying to make sure everybody's on the same page, and we're doing what's right for the patient. And it's really for those individuals who have this life-threatening illness that we're there to be that extra layer of support. I love palliative care. This is why a lot of us went into medicine in the first place, because we really thought we were going to be able to sit at the bedside and help people and not just come in and fix hearts or lungs or kidneys, but people. And that's what palliative care is. So it's a subspecialty of medicine, not focused on curing of disease. We don't deal with organs. Instead, we focus on alleviating suffering and increasing quality of life. Got to be the coolest thing we ever did, right? Palliative care is awesome. So how is palliative care different from hospice? A lot of people get confused. They think, well, we're calling palliative care, that must be the end, right? So how does it differ? So palliative care is provided by a team of physicians, nurses, social workers, chaplains, and others focused on alleviating suffering and improved quality. Whereas hospice is provided by a team of physicians, nurses, social workers, chaplains, and others focused on alleviating suffering and improved quality. Clear as mud, right? The more important thing is, palliative care is applicable regardless of the stage of the disease and need for other therapies, whereas hospice really is that last 6 months of life when no other curative therapies are appropriate or desired. If you have heart disease and we think you're going to live for 5 more years, can you go into hospice? No, you're not eligible. Can you go into palliative care? Absolutely. Doesn't matter where you are in the disease process. Can you go into hospice if you want to keep getting chemotherapy? No, you've got to make the decision for hospice that, you know what, I don't think more chemotherapy is going to do me any good. Can you keep getting chemotherapy and be in palliative care? Yes. The whole idea behind palliative care is that extra layer of support for people who have serious illness, but you don't have to say, this is the end. You can continue to do what's right for you throughout the however long you have left, whether it be 6 months, 6 years, 16 years, it doesn't matter. This is cool stuff. We have a palliative team that wanders about through the hospital looking for lost souls. No, it's a consult, like you would consult a pulmonologist, or you would consult a renal doctor, or you would consult any other doctor. You can consult the palliative team, and you would have a team of people that would come and sit down and talk to you. And really what we find is it's when people get to a point, much like Mrs. Jones here, I try to use a very, very typical case, she's very frustrated. She doesn't know which direction to go. Am I doing the right thing? Is this right? And so the palliative team would come in and talk with Mrs. Jones, and they would say, what are your goals? What would you like to see? What do you want to accomplish yet? Do you want to try to stay at home? Are you tired of coming back to the hospital? What are your goals? How do we help you best? And then we tailor her medical care to try to meet her goals. And that's not always easy. You know, some people may have very unrealistic goals. People that say, I want to live 10 more years. And you look at them and go, that's probably not going to happen. Has anybody ever come in and told you that you're probably not going to live 10 more years? And that in and of itself is a conversation, right? There is no reimbursement for palliative care at all. So it's supported by the hospital. And the hospital says, we see the value in having a team of people in our hospital providing this care outweighs the cost. And I'll be honest with you, in 2007, I started trying to get a palliative team at the hospital. We got one finally in 2013 because there's no financial reward for it. If I had wanted to buy a new machine that made chocolate yogurt in the cafeteria, I probably could have gotten that in 6 months. But putting together a team that isn't paid for is a fiscal challenge. Now, if a physician comes to see you in the outpatient setting, the physician can bill your insurance. If a nurse practitioner comes and sees, they can bill your insurance for a visit. For the team itself, it's an uncovered entity. Now, there are some insurances out there, Blue Cross, Wellmark, a couple of them, that are looking at this as an experiment because they recognize that having people come out and be this extra layer of support is actually beneficial to the patients. They recognize that it's a service, and they're looking at paying for it. Nobody wants to pay for more. So I don't know where that's going to go. I'm hopeful that they will see it as valuable enough that they will pay for it. But in the meantime, for right now, it's the hospital system. Both Unity Point and Genesis both have palliative teams in the hospital, and it's both basically just the hospital system saying, we say this is important enough, we need to have it. So palliative team is actually sponsored. I'm actually board certified in palliative care, and it's actually sponsored by 11 specialties. Geriatrics is one of them. Family medicine, internal medicine, emergency medicine, surgery, gyne, oncology, and I don't know if I'm going to be able to remember all 11. But it's all the areas of medicine have really come together to say this is an important area of medicine and we need to sponsor this. So not just geriatrics, but that is one of many areas that felt that this was needed. So it's a rare occasion when almost all of medicine comes together and says this is important. So it's kind of a neat thing. I'm a firm believer that 99% of all errors that happen in healthcare are because of communication. I mean, talking is so important. Having somebody who's just watching the patient and managing the patient rather than watching the heart or watching the lungs or watching the kidneys or watching the, is so important. And that's not to say that cardiologists don't watch the patient as well, but they're really focused on their organ. I'm going to flip through a couple of things here quick. Just for the fun of it, do people live longer, shorter, or the same if they have palliative care? They actually live longer. So there's good studies out there. This one just happens to be with lung cancer, but they actually found that people actually had a better quality of life, decreased depression, decreased aggressive care, and a longer median survival than they would have had if they had gotten all the usual cares. Having these conversations doesn't mean you're just asking for less, right? It just means what's important to you and how do we best do that. Oftentimes, and what we're finding is that studies are showing that if you do get palliative care, you live longer. All right, back to our case. Mrs. Jones continues to decline. After several hospital stays and skilled stays to try to regain her strength, she makes a decision, I'm just not going back to the hospital anymore. I don't want to keep doing this. I just want to be at home. So the question becomes, can she do this? Are you allowed to say, I don't want to do this? Isn't that crazy? I mean, you have the right. Is there anyone that can help her remain in her home? So this is where we go. This is where we say palliative care probably isn't the right answer anymore, but hospice care probably is. So hospice care has been around since '67. This is a quote by Dame Cicely Saunders. She's the founder of hospice. You matter to the last moment of your life, and we will do all we can, not only to help you die peacefully, but to live until you die. And she was she was an oncology nurse. She's in Great Britain in the oncology wards, and she just saw people suffering and having pain and absolutely miserable right up to the last day of their life. And she said, we got to find a better way of doing it than this. And so she kind of founded this hospice movement. It came to the United States back in the 70s. It didn't really take off until 1983 when Medicare started paying for it. So now, if I were to ask you, what percentage of people in the United States die with hospice services on board? What would your guess be? I'm hearing low numbers. 5, 10, 25, 70. You're a little optimistic. It's right at 50. It's right at 50%, which I think is fabulous and nowhere near where it needs to be. Okay, so true story. I was actually at a conference one time, and I was sitting at this table next to the lady who is in charge of all hospice services in New Zealand. Now, New Zealand has a single-payer system, so the government decides what people are allowed to have, and hospice services are part of what is their national health care. And we asked her, we were going around the table talking about all the frustrations that we had getting people into hospice and physicians, accepting hospice and seeing hospice as value, what have you. And we got to her and we said, so do you have these same problems in New Zealand? And she looked at us, she goes, no. In New Zealand, if we didn't offer hospice services, people would be in a riot and they'd be suing us because they didn't get all the services that they were entitled to. It was complete opposite, right? It was like, of course you would have this service available to you at the end of life, that you'd have extra nurses and extra care and all your medicines paid for and all the care paid for and all these things that hospice. Why would you say no to that? So I think 50% sounds good, but it should be much higher. Why would anybody say, I don't want all this extra services at the end of my life? So remember we talked about what is the goal? We want people to enter hospice when they have how long to live? 6 months. In this community, how long do most people have when they enter hospice? Roughly. 21 days. 21 days in this community. That means that we are 5+ months off in getting people into hospice. In hospice, are the nurses paid for? Yes. Are the aides paid for? Yes. Are the chaplains paid for? Yes. Are the social workers paid for? Yes. Are the physicians paid for? Yes. Are the medicines paid for? Yes. Are the medicines that have to do with your illness that you're in hospice for? Now, if you say, I also want to take this, expensive vitamin that I, ship from Australia, no, you got to pay for that one. Is the hospital bed paid for? Yes. Is the commode paid for? Yes. Any other durable equipment that you need, is it paid for? Yes. All of this is paid for. The question becomes, why would you say no? And again, it comes down to you have to say, I recognize that I'm in my last 6 months. You know, and if you got a sister with significant liver disease, could she have been in hospice for a year? Yes. You can be in hospice longer than 6 months. Our goal is just to try to make it a minimum of 6 months. And we're way off. So obviously, the hospice philosophy provides sensitivity and support for patients and their families, enable patients to carry on an alert, pain-free life, or as close to pain-free as we can get it, and to manage their symptoms so that they may have dignity and quality, and to recognize dying as a natural part of life. Most important thing I want to leave you with, this is a national study looking at the National Hospice and Palliative Care Association. They did a satisfaction survey. What was the one thing that they saw more than any other comment made about hospice? Why didn't my doctor tell me about this sooner? It's an amazing thing. And we would rather, I look at it this way. When a person is first told that they have a terminal illness, the first thing that they do is say, I don't believe it, right? This isn't true. I'm going to get another opinion. This can't be right, right? There's doubt, all right? That takes a while to get through that stage of doubt, right? And then what? Maybe some anger. Why did this happen to me? This isn't fair. I don't deserve this. I got so much that I'm living for, you know, all these things. And you got all that. And then you got to get to this point where you have acceptance. And you finally say, okay, I get it. I've got this terminal illness. I'm going to deal with this. What do I got to do to deal with this? Is that about 5 minutes each? Maybe 5 days each? Maybe a month each? How can you get the most benefit out of hospice if you're only in for 21 days? If you're still in those early stages of I'm dealing with this disease process. And the goal is to have people in there for a long period of time so that you can be there to help them. You know, maybe there's family members that they need to reconcile with. Maybe they need to make sure that their family is financially solvent. Maybe they need to, you know, what's important to them and how do we deal with what's important to them? And that takes time. So our goal is to try to get people in much sooner than we do. 5 months and 29 days would be just about perfect. This is the #1 statement in a national survey regarding hospice. Why didn't my doctor tell me about this sooner? So I'm here to tell you about it a lot sooner. That's all I had. Just a little over an hour. I apologize, but thank you. I appreciate it.